So our next speaker is Martha Dina Arguello. For the past 32 years, Martha has served in the nonprofit sector as an advocate, community organizer, and coalition builder. She joined Physicians for Social Responsibility, known as PSR, LA in 1998 to launch the environmental health program. She became the executive director in November of 2007. She is committed to making the credible voice of physicians a powerful instrument for transforming California and our planet into a more peaceful and healthy place. As a coalition builder, Martha has emphasized the need for local grassroots advocacy, working in partnership with statewide policy actions. She is an active member of numerous organizations, including Californians for Pesticide Reform, the California Environmental Rights Alliance, and Californians for a Healthy and Green Economy. She also co-founded the Los Angeles County Asthma Coalition, the Coalition for Environmental Health and Justice, and was appointed to California's EPA Environmental Justice Committee and the California Air Resources Board's Global Warming Environmental Justice Advisory Committee. Welcome, Martha.
Thank you. I do want to say that before all of my work at Physicians for Social Responsibility, I was a health educator and have spent a lot of time working both in how to educate communities and how to change clinical practice and educate physicians. And that, that work, I did work at AIDS and helped develop some of the first sort of social interventions around AIDS testing for Latinos, went on to help create a health education department around breast cancer and early detection. So I have a long history of working both with providers and communities. And so I want to thank you for the opportunity to talk today about the guidance. And I think it's incredibly important for us to increase the amount of testing and biomonitoring that we're doing. One, because many communities are facing this problem and don't know it. So particularly in Southern California, there's lots of wells that have been contaminated. I'm not going to do data heavy because I have a sense you're all the scientists. And so I'm going to really focus on sort of the health education and social justice dimensions of the guidance and what we need. And so we know it's a widespread issue, particularly around water contamination. Got LA in the background. What you can't see in that beautiful sunset is our industrial past. That is where we've done lots of heavy manufacturing and construction, heavy manufacturing, chemical production, the aerospace industry, and many of these industries have left a profound legacy of contamination throughout our communities. And so we often face multiple exposures to multiple chemicals. And so approaches that only look at one chemical at a time are not sufficient to really give the sense of the riskscape that communities face. So in light of that past, we have found we've been doing, trying to build capacity of different organizations in Southern California to take on issues of water contamination. And what we found is people don't trust their water. So we often don't ask, what does it mean for communities? My niece is 12 years old and she's never really had tap water. She's drank mostly bottled water, and I can't seem to get my own family to figure out we should be using filtration systems. Bottled water raises other issues, but that is what our communities are doing. So Latinos pay more per capita for water than we do for fuel, for gasoline, because we just don't trust those systems. And testing and proper health education and clinical education to communities is key to helping us build that trust. But this is what I would say. When scientists fear speaking truth to power, we know that truth dies. And what communities face often, and I see sort of problematic embedded in the guidance, is a minimization of our anxieties and risks around exposure. So if somebody comes in to your to a clinical office and says, here's my water quality report, and these levels are really high, what does this mean for my health? The only response can't be, don't worry, be healthier, so you reduce your risk of other things. That is not an adequate response to communities. And what I often hear when we do a lot of training with physicians, do a lot of training with communities, and often folks who've actually gone to physicians about some exposure or chronic health problem that may be related to an exposure, whether it's living next to an oil well or, you know, the water that comes out of your faucet is highly contaminated, they hear the same thing. It's not what you've been exposed to. And so that lack of training and that lack of ability of clinicians to actually validate the lived experience of communities and saying, yeah, you're exposed to a lot of different things. Here's how you could reduce your risk. That's an essential part of a guidance. And it is an essential part, because now I'm going to put my advocacy hat on. We can't change this broken system without the partnership of science and physicians. And I'll give you a really perfect example of how this plays out in real life. In California, we've done a lot of legislative work around PFAS and PFOAs and many chemicals, and I'm not going to get into the details. But I do know the battle over the science that we've had to wage in convincing legislators that this is a problem and that we need to act and that we should be listening to the early warning systems that we see reflected in when we do water testing and when we start doing biomonitoring, right? Those are public health early warning systems that we're not acting on. There is a physician legislator in Sacramento who actually has said, you know what, I don't think we should be disclosing these things because the worry is worse than the exposure. And that is how physicians are traditionally trained. And so when a community member goes in and says, I've been exposed to this, may I be sick? That is a failure of us keeping our trust to do no harm. If we send that patient away, making them feel it's just your anxiety, worry less, right? What we should be saying is, yeah, these shouldn't be in your water systems. You know, maybe you want to call your water agency to find out what's going on, right? Because we need actually to change the system, and we don't heal our patients by just acting in the clinical setting. And so it's important that the current guidance actually think about anticipatory guidance in terms of, you know, being serious about checking out what water treatment systems like and having some physicians and nurses having some literacy around what those water quality reports mean, what TMDLs mean, what safety data means. You know, California has stricter standards, but that still, you know, allows us to be exposed to a certain amount of chemicals. And we actually really don't know what that means when it interacts with the other things that people are exposed to. So in one community where we work with, they've been exposed to, there was a fire at a partial nuclear meltdown. There's lots of chemicals, and then there was a fire. And communities aren't fully being told, well, what are the contaminants that are now in my water that are going to run off from the fire retardants that we use to suppress the fire and the chemicals that are going to be released in the fire, right? Furniture, carpeting, household chemicals. All of those things, we are now telling those communities that are in that fire zone, everything's fine. So we actually need physicians to step forward because we have regulatory agencies that are actually not preventing that exposure. So you are an incredibly important backstop to the tools that we need to actually change the systems and act on the early warnings that we've been ignoring for way too long. I want to also talk a little bit about, in this guidance, what I don't see is a type of stratification. A high-income patient from the west side of LA in Santa Monica who's really concerned with exposure and is figuring out ways to buy her furniture, her bedding, everything without flame retardants, comes to you and wants a test. That's essentially different than, let's say, a young woman who lives in a low-income community, not so far from the freeway, who's also may have exposure because of the water systems, but also lives next to a refinery. The intervention there is incredibly different. This person cannot buy themselves out of being exposed. And your exposure assessment and your risk reduction strategies need to be based on that. And there are great models for doing that. So in LA, we've done a lot of work around lead and mold and roach infestations in substandard housing. So instead of acting like this is a slum tenant, this is a slum landlord, and doctors are actually writing prescriptions for new carpeting, for other asthma mitigation, for low-risk pest management to reduce the roach infestations. So I would imagine that in our ways of risk reduction, we would be doing the same things. Where is your exposure indoors? Is it coming from your carpeting? Is it coming from other products? Where you live matters, right? And integrating geospatial tools so that we understand where you live and what that means for your level of exposure and your cumulative exposure and your overall risk is really important. So we've done a tool called the 500-foot tool, where we took all available data around pollution sources in 5 zip codes, verified all the sources, and so you can now enter your address. And now we're integrating that into clinical education, so a physician can enter the patient's address and figure out, this is, now I start to get a sense of the risk and hazard escape for this particular person and community, because place matters, particularly when it relates to exposures. And then the other part, you know, again, my advocacy hat, is we actually need tools as advocates to show science to the regulatory agencies that will move us toward better upstream solutions. So right now we're very focused on what is the end of life of anything that has PFAS, because it will end up in a low-income community and exposing more communities of color. So our policy choices around removing them from consumer products has to be supported by a robust effort around what are the mitigation measures? How do we actually get it out of water? And in California, where we've declared that, you know, water is a human right, there is so much investment right now in that infrastructure. And we need to have the best available data. Testing has to be widespread so that we could see where exposures are concentrated and where we need to focus our solutions. And, you know, it gets really complicated because I don't know where you all live, but in California, and particularly in many parts, how we manage water is so arcane that it doesn't often allow for us to do precautionary or real upstream solutions. And so we're often short-sighted. But most important, we need a strong guidance that doesn't minimize the risk of exposure, because we need to change the culture of healthcare so that physicians aren't just getting 6 hours of training in environmental health. They're actually understanding the role of systemic racism, of environmental racism on health and the impacts of their patients, and why they are probably being exposed to more chemicals in many different ways than a higher income person living on in a high income zip code. Because in many places, we know that zip code determines life expectancy and probably exposure. So I'll stop to see if folks have questions.
Thank you, Martha. You hit so many excellent topics. One being that physicians who don't know a lot about a topic will often say, oh, don't worry about that. And it often is because the physician doesn't know enough about it. So you hit a good point there. And you also hit another good point in the fact that when we set up these guidelines for physicians, we do need to do a massive education process too, because many physicians don't understand or don't even know what the word PFAS is. And your environmental justice issue is a tremendous issue that needs to be heard at. I wish that I could have you come speak at the medical schools, because that's who I want you to talk to. So what I'm going to do is have the next speaker speak, Martha, and then we'll do questions at the end of that, if that's okay. All right.